Now I request the next speaker, Professor Mantosh Pancha. He is going to talk to us on post-cardiac intervention, stent bypass or patient due to non-cardiac surgery, guidelines of management regarding antiplatelet drugs, beta blockers and statins.
So this is a very important subject for the interventional cardiologists, clinical cardiology, all the physicians. Because after the angioplasty, after bypass surgery, so many complications may arise. The stent thrombosis on the burden and very late thrombosis per year, 0.6%. And there is stenosis another problem, and some aneurysm also problem. So that group of patient, you have to treat the familial diabetes, hypertension, so many drugs, beta blockers, statin, everything getting. So you have to think what to be done if we require the non-cardiac surgery. If we stop the antiplatelet therapy, so the chance of stent thrombosis is there, and stones should be more. And again, if you continue the antiplatelet therapy and do the non-cardiac surgery, chance of bleeding of the non-cardiac surgery. So you have to go a balanced way. So according to guidelines, we have to do in such way. So issue is that cardiac issue in non-cardiac surgery, you have to find out the patient's risks at first, whether coronary heart disease, hypertension, diabetes. Then some non-cardiac surgery, what is the procedural risk on non-cardiac surgery? Therefore, this is very find out, so before whether the patient is risk factor for intermediate or high risk factor. So accordingly, you have to settle the management program, medical management, according to guideline of ACC and American College of American Heart Association. Try to find out the cardiac risks. Otherwise, you cannot plan out for the cardiac, non-cardiac surgery. You have three groups on the, that means after the, during this, if you do the surgery, some cardiac manifestation may be happen. One is the, some group of patients high risk. That means the death, cardiac death and non-fatal marker infarction is more than 5% chance if you do the non-cardiac surgery. So these are the, that's complication, high risk. That means this group of patient, so emergency operation, particularly elderly patient having the coronary heart disease, angioplasty, CABG, chance of cardiac problem is more than 5%. If you do some surgery for ascending aorta, thoracic aorta, descending aorta, any major vascular complication, that cases manifestation cardiac death and MI will be about more than 5%. Similarly, perivascular surgery or any surgery, non-cardiac surgery anticipated for prolonged procedure when chance of large fluid shift or blood loss. So therefore, that is the happen chance of death and MI, that is more than 5%. And when the intermediate risk group, that means if you do the surgery of a carotid artery, head neck surgery, interperitoneal, intrathoracic surgery, orthopedic surgery, prostate operation, in that group of patient, the death, MI chances, they're 1 to 5%, that is less than 5%, that is the intermediate group. Low group, the death MI will be less than 1%, particularly if you do this, that is going to define of the low risk group, but when there's some endoscopic procedure, superficial procedure, when it's skin operation, cataract and breast operation. So keeping in mind, you have to take a decision when to operate. Why perioperative cardiovascular event death might happen during the non-cardiac surgery? Keep in mind, very, very important question for postgraduate. So during the non-cardiac surgery, in presence of a heart, post-PCI, post-CABG patient, the catecholamine surge will be excessive. Second, the prothrombin molecule also may more. And chance of blood loss is there, and volume shift also there. And coronary flux destabilization also happen, of course, in presence of the fixed coronary artery disease. Let us do. Do you need to stop the antiplatelet, anticoagulation? Yes, there is a problem is that I already spoken, chance of stent thrombosis and sudden cardiac death may be there. And chance of restenosis will be there. So therefore, you have to find out, and otherwise, no, chance of bleeding also there. If you not stop it during the non-cardiac surgery, bleeding manifestation more. Of course, keep in mind, low risk for bleeding, particularly arthrocentesis, cataract operation, dental cleaning or extraction, cutaneous surgery, these low risks. That cases, without stopping the antiplatelet, anticoagulation, you can do the surgery. There is no problem at all. Let us see. The commonest problem, I am in the interventional cardiologist, so we are doing the bare stent and the drug-eluting stent. So what will happen in the bare stent if you require some non-cardiac surgery? So you have to wait, delay the elective procedure at least 1 month Today is bed stent is given, so you have to wait at least 1 month, preferably 6 months. Otherwise, chance of stent thrombosis will be there. And bed stent, particularly minimum 1 month should be crossed. That cases, yes, you can go ahead for the stent, and the stent plus continue dual antiplatelet therapy is no problem. But bleeding source, bleeding chance is more. That cases you have to wait. In case of plain balloon angioplasty, no stent. So in that cases, you have to wait minimum 14 days, 14 to 29. So after that you can do it. So in case of bare stent, minimum 30 days cross. So in between 30 days to 365 days ideal time for the bare stent for non-cardiac surgery. But in the drug-eluting stent, you have to delay it for 365 days. Otherwise, chance of stent thrombosis resistance is more. Keep in mind, it is according to guideline. So therefore, on expert opinion, so proposed approach by management of the patient with previous angioplasty who required the non-cardiac surgery, best expert opinion. This is very important issue. In case of the balloon angioplasty only, so what is the, on the plain balloon angioplasty, if it is less than 14 days, you have to delay it, and or non-urgent surgery. And if you cross the 14 days, you can proceed for the operation, but you can stop the cooperative, but aspirin to be continued. That's very keep in mind. Very, very important issue. Don't be afraid to continue the aspirin in the plain balloon angioplasty. But in the case of bare stent, when that is more than 30 days for 45 days, you proceed for the operation room with aspirin. Don't stop the aspirin. We have to stop the cooperative only. This is a very vital issue for the physician and cardiologist. Again, less than 30 to 45 days, you have to delay the elective procedure even in the bare stent. But in cases of drug-eluting stent, you see, less than 65 days, you have to delay. There is no chance of stent thrombosis with there. In cases of when it crosses the 365 days, again you can go ahead for the surgery with aspirin, keep in mind, you can stop the cooperative. This is the very, very important issue. Earlier decision taken 2007. Now let us see what is evidence medicine from the decreased studies. Ischemic events, particularly commonest cause of the death, NMI, mortality and morbidity. At least 10 to 40% of the perioperative mortality because of myocardial infarction. So therefore there is enough influence of the drug like beta blockers, which influence the myocardial oxygen balance. And some drugs, statin, improve the plaque stability, which is maybe responsible for reduce the perioperative mortality. And bisoprolol study, and the decreased one study shows bisoprolol reduce the both short and long-term cardiac death and MI. Now, decrease 2 shows bisoprolol, what is happening, they maintain the heart rate, particularly presence of the intermediate risk group for non-cardiac surgery, and therefore the death and MI significantly reduced. And decrease studies 3, that is statin is very important. Statin reduce the myocardial ischemia, and combined endpoint cardiovascular death and MI is very significantly low in high risk group where the major vascular surgery needed. And decreased 4th study found bisoprolol, very important drug, reduced 30 days cardiac death and MI in the intermediate risk group, of course with the benefits along with the statin, which is very, very beneficial. Beta blocker use, decreased study shows, is very important trial, multi-central trial, and they use the bisoprolol 5 to 10 milligram per day, at least 37 earlier for the undergoing the surgery. So risk is that very important issue. You see, in cases of the compared to standard is the 30% death and MI, and 30 days mortality is 34%. And if you use the bisoprolol, the death MI significantly reduced 17%. Very, very important drug. Now, in cases of diabetes, the deformed study shows the metoprolol use. They showed that there is no metoprolol. If the metoprolol use, that case is not beneficial. Death, MI, unstable angina, not beneficial. However, the current guidelines, they recommend the use of the beta blocker, but it is beneficial only, recommended only for subgroup of patient. Now, recommended the beta blocker. The class 1 beta, the indication is that is somebody getting the beta blocker for angina, so symptomatic arrhythmia, hypertension. So you have to continue the beta blocker even for non-cardiac surgery. Don't stop it. In case of the class 1 indication, patient particularly undergoing planning for vascular surgery, but a high risk patient, you have to start the beta blocker. Very, very important issue. And class 1A indication, beta blocker is probably recommended if there is some established coronary heart disease or PCI and post-CABG. Again, beta blocker is probably recommended if it is more than one risk factors. Again, beta blocker is probably recommended if more than one clinical risk factors who require the non-cardiac surgery. Now, beta blocker recommended for medical therapy is class 2B indication, uncertain for those of intermediate risk procedures. Again, beta blocker is uncertain patient of no clinical risk factors. And class 3 is the not beta blocker should be prescribed when there is a contraindication of beta blocker. In cases of beta blocker use, you see at a long time study, the published in JIMA 2096, long time well established. If you treated the patient with the atenolol prior to this, for the surgery, you see, improve the survival with the atenolol after the non-cardiac surgery, very, very useful drug. Then recommendation statin, the class 1 indication, you see, currently taking, somebody getting the statin, you have to continue the statin, don't stop it at all. So it should be continued. Second, class 1A indication for patient undergoing vascular surgery who is without clinical manifestation, statin is reasonable. Again, class 2B, it is some definitely statin to be considered. Therefore, conclusion, ladies and gentlemen, apart from the antiplatelet dual antiplatelet therapy, apart from the beta blocker, apart from the use of the statin, some other drugs to be kept in mind, and beta blocker to continue, but this calcium channel alpha agonist to be continue, statin to be continue, and diuretic as when needed, but this ACE inhibitor during the procedure you have to stop it, because fluctuation of blood pressure may create the problem for hypertension, which will be responsible for sudden cardiac death, non-cardiac macular infarction. Thank you very much indeed for patient hearing.
Any questions? Sir, thank you. If it is an emergency surgery, how do you proceed?
Yes, if it is emergency surgery, you stop the copidogrel and do the operation with aspirin. I have to prevent the stent thrombosis, very, very important. You have to continue aspirin, not create the problem.